Hey everyone, it's Mikki here. You're listening to Wikipedia, and this week on the podcast, I speak to Dr. Terry Boyle. I'm stoked that I get the opportunity to chat to epidemiologist Dr. Terry Boyle from the University of South Australia, all about cancer risk and exercise. So we talk about more broadly the increase in cancer cases worldwide and what might be at the heart of that increasing prevalence, including the overall risk of sedentary behaviour. We also talk about what sedentary behaviour actually is, so how we define that, and why it might be increasing the risk of different types of cancers. We also discuss exercise in depth, how it can help both psychologically and physically someone who is going through cancer treatment, the relationship between exercise and cancer risk, and some of the misconceptions that might be out there about using exercise alongside other therapies for cancer to help improve overall health and well-being. Dr. Boyle and I also discuss looking at lifestyle and genetic factors and how important these are at cancer risk, and then briefly touch on the recurrence of cancer and what might impact someone's risk of getting a secondary cancer or getting another cancer diagnosis after having one diagnosis. So I found this a super interesting conversation, really different from the conversation I had with Professor Tom Seyfried, but I think a really important exploration of some of the lifestyle contributors and just the epidemiological data around cancer. And Dr. Boyle and I discuss, the quality of this data, because of course we know that with regards to nutrition epidemiology, you can't take much away from that data. So I think you're going to find this a super interesting conversation. So I have a link to Dr. Boyle's profile at University of South Australia, and he is an epidemiologist in the Australian Centre for Precision Health. He has a broad interest in lifestyle factors and chronic disease, with a focus on the role that physical activity and sedentary behaviour play in cancer risk, cancer survival, and cancer survivorship. While he conducts research on a range of cancers, his recent studies have been on blood cancers such as non-Hodgkin lymphoma. Terry received his PhD from University of Western Australia in 2012, then received fellowships from the Australian National Health and Medical Research Council and the Canadian Institutes for Health Research, which gave him the opportunity to spend 2 years at the British Columbia Cancer Agency at the University of British Columbia in Vancouver, in Canada, and he joined University of South Australia in October 2017. Terry has a range of experience in epidemiological and biostatistical methods, including multiple imputation, meta-analysis, and a whole bunch of other statistical methods, which allows him to analyse data sets and make inferences from that. And this is what we discuss in this podcast here. Before we crack on into the interview though, I would like to remind you that the best way to support this podcast is to hit subscribe on your favourite podcast listening platform, because that increases the visibility of Wikipedia and amongst literally thousands of other podcasts that are out there. So more people get the opportunity to learn from the research that's currently being explored from people like Dr. Terry Boyle. All right team, enjoy this conversation. I totally appreciate it. So Terry, you're a senior lecturer in cancer epidemiology. Can you just start by giving us a little bit of your background and how you got into the field of investigating population risk of cancer with lifestyle? How did that come about?
Yeah, sure. To be honest, I kind of fell into it. So I got a research assistant job, it was probably about 5 or so years after my actual undergraduate degree, which was in human movement and exercise science. That's my kind of undergraduate background. So I got a research assistant position on a case control study looking at risk factors for colorectal cancer at the University of Western Australia, and I guess that was my kind of first taste of epidemiology and cancer research. And I just like a month or so into that position, I just knew this was an avenue I wanted to pursue as a career. I was working with some excellent epidemiologists and mentors, Professor Lynn Fricci, Professor Jane Hayworth there, and then they were excellent people. So then I went on to do a PhD using data from that study, looking at physical activity and risk of colorectal cancer, and also sedentary behaviour and risk of colorectal cancer. And then I guess since then I've really continued that kind of avenue of research, looking at those lifestyle related risk factors and predominantly cancer risk and also cancer survivorship and cancer survival and more broad, I guess, chronic disease more broadly as well. And I guess I find it really rewarding to work in this area because cancer is something that affects everyone. On a personal level, my grandparents passed away from cancer, which are probably we know now probably preventable cancers. So it's really rewarding to play a very, very small role in trying to work out how we can prevent cancer and how we can improve the quality of life and quantity of life in people who have been diagnosed with cancer.
Yeah, nice. And nutrition is my background, and in nutrition, epidemiology is what is relied upon to give us data that informs like public health recommendations, and also it also informs newspaper headlines and clickbait media and all the rest of it. And I guess like one of the probably fair criticisms in nutrition epidemiology is that it's not based on great data. So what's it like in the field of cancer?
I think I guess when we're talking about nutritional epidemiology and physical activity epidemiology as well, I guess they're really challenging things to measure. So I think that really raises a lot of challenges. And I guess, and also it's because, like you say, to kind of know about how things like nutrition and physical activity influence those like chronic diseases like cancer and cardiovascular disease and so on. It's really, really difficult to do a randomized control trial, which is kind of the gold standard for looking at what causes what. So we really rely on those on observational epidemiological studies and there are certainly lots of challenges and things that you need to think about. That's one of the areas one of the aspects I really enjoy is thinking there are all those methodological challenges that we need to think about. So I know we have lots of time thinking about confounding and different kinds of biases and measurement of how we can better measure those exposures.
Yeah. And I also think, like scientists, epidemiologists always go in thinking like the type of studies that are conducted, like, as I understand it, they are hypothesis generating. That's like, well, this is super interesting. I wonder where this leads. Whereas often what people who might be clicking on a clickbait headline, what they'll be reading is almost like, oh, this is a foregone conclusion. Whereas the people doing the science are like, well, super interesting. Let's head down this road, I imagine.
Yeah, I think, yes, sometimes there's a big difference, I think, sometimes in what the researchers might write about in their manuscript or their studies versus then what then goes on to get reported on the media. And I think there's kind of been studies that, sometimes that's not, like, I think that sometimes that is the fault of researchers and PR departments at universities, so I think it's definitely not fair to lay the blame on journalists there. But I think, as I guess I know, I'm always quite cautious when I'm talking about the results of studies that I've done, given it's just one study. And I guess what you like to see in epidemiology when we're doing these kind of observational studies is really lots and lots of studies maybe conducted in different populations, that have different kinds of studies or different kinds of study designs, but all showing the same kind of results, and that can kind of gives a lot more confidence in whether a particular exposure is increasing or decreasing the risk of a particular cancer.
Yeah, nice one. So, Terry, I want to ask you sort of some broad questions about cancer and cancer risk, and then narrow it down to an area which I know you've done quite a bit of research in, which is, of course, sedentary behaviour. First of all, what is lifetime risk of cancer? And actually, what does that mean? I think that's that's a question I've got as well. And then how has it changed over time?
Yeah, so in terms of lifetime risk of cancer, so I'm just going to talk about Australia because I guess that's what I'm more familiar with. But I'm sure the results, think the figures would be very, very similar in New Zealand and probably most developed countries around the world. So in Australia, I think the latest information I could find was from 2022, and it's estimated that around 40. So lifetime risk is 43%. Basically, so that really means that if everyone in the population lived to the age of 85, then and based on the cancer rates that we see today, then around 43% or 2 in 5 of those people would be diagnosed with a cancer before they turn 85.
Wow.
That's it. And it's a bit higher in males and a little bit lower in females, as we know that males are at higher risk of cancer than females. And in terms of how that's changed, that lifetime risk of cancer has changed. It's actually been pretty steady over the last 20 or so years. So I looked at in around 2014, it was very, very similar. So the lifetime risk or the risk of being diagnosed with cancer before the age of 85 was about 1 in 2 for males and 1 in 3 for females, and overall about 2 in 5. And similarly, about 10 years before that, in the kind of mid 2000s, it was really quite similar to that as well. So that lifetime risk seems to have been pretty steady over the last 20 or so years. When you actually think about the number of new cases, though, that has increased like massively over the last 20 or so years. So I think it's increased about 90%, but that's primarily due just to the growing population and also the aging population. So the actual, at that kind of absolute level, the number of cases has absolutely increased, but it seems like the incidence rate seems to have been fairly steady over the last maybe 10 to 20 years.
Yeah. Terry, what is it that places males more at risk than females? Do we know?
I think probably a lot of it, is just due to the common types of cancer that males and females. I think prostate cancer is, the incidence is a bit higher than female breast cancer. And I guess also there's probably some risk factor elements. I guess historically smoke, like lung cancer rates are higher among males than females, even now still, and that I guess historically because males were much more likely to smoke than females were.
Yeah, interesting. And it's interesting how you say that the absolute numbers have increased despite the lifetime risk staying the same. Out of the cancers that people are being diagnosed with, have there been an increase in some cancers versus others? Like, I don't know, I wonder whether lung cancer actually I wouldn't know where lung cancer was in light of the changes in smoking and whether it's had a time to decrease yet. But what's changed? Anything changed in the types of cancers that people are being diagnosed with?
Yes and no. In terms of the most common type of cancers, if you look back 20 or so years ago, the five most commonly diagnosed cancers were breast cancer, prostate cancer, colorectal cancer, lung cancer, and melanoma. And nowadays, they are still absolutely the top 5 most commonly diagnosed cancer. But there are some cancers where the incidence rate has increased over the last few decades. And I guess some examples are thyroid cancer, liver cancer, and kidney cancer. And conversely, there's some cancers for which have seen a decline in incidence. And interesting that you mentioned lung cancer, because that's absolutely one. Among males, the lung cancer rates have been decreasing, but among females have actually been increasing, and that's probably almost exclusively driven by those historical changes in smoking rates. So males were much more likely to smoke. So I guess and lung cancer is still much more common in males than females. So I guess it kind of there's a higher point for it to start decreasing from, I guess, if that makes sense. And another example, more recent example, is cervical cancer and the introduction of the HPV vaccine, and that's seen a quite sharp drop in the incidence among cervical cancer in young women, so females aged under 30, which is a really positive public health story, I think.
Yeah, that's amazing. And what about, Terry, you mentioned that thyroid cancer and liver cancer has increased. I mean, it's fine if you don't know, but any ideas why that would be?
Yeah, no, I don't. No, I don't, to be honest. I haven't actually ever done any research into either of those cancers. Yeah, so I don't. Yeah, that's not something I can really talk about. Sorry.
Yeah, it's interesting though, isn't it?
Yeah, I think probably part of what we're seeing in Australia in terms of those, the difference increases in some of those rarer type of cancer. Some of that is probably driven by migration patterns. So we know with people with different ethnicities have higher risks of some particular diseases for lots of different reasons. So sometimes they kind of, when they move to Australia, they kind of bring that increased risk for that particular cancer with them. So sometimes, those kind of migration patterns can play a part in the kind of cancers that we see.
Yeah. No, that makes perfect sense. And are people being diagnosed younger nowadays, or is it just that we hear more about it because of what we see on the news or social media, or I don't know, those headlines that we were sort of talking about?
I've noticed that as well in the headlines in the last few years, that there seems to be quite a few stories coming up about the younger people being diagnosed with cancer more often. So I had a look into that, and there absolutely has been an increase in incidence in cancer among younger people, so adults age under 50. So in the US, there was a report from the American Cancer Society last year where they really found this quite a clear shift in the demographics of people diagnosed with cancer. So it's increasingly shifting from older individuals to middle-aged individuals.
Yeah.
I think so. Cancer is absolutely still much more commonly diagnosed among older adults, but there certainly seems to be an increase in incidence in early onset cancers. And there was actually a study just from earlier this year which looked at the incidence of early onset cancers at a global level, and they found that they'd increased by about 79% from between 1990 and 2019. Which is a huge increase in incidence among older adults, and in particular breast cancer, tracheal cancer, bronchus and lung cancer, stomach cancer, and colorectal cancer in particular seem to be causing the kind of most disease and death in that younger age group. So I think there's lots of research going on at the moment trying to work out what's driving the increased rate of these early onset cancers.
And of course, your area is in sort of lifestyle. Well, I think lifestyle, looking at like physical activity, a large part of that. Like if you put your epidemiology hat on, do you sort of think, actually, you know what, like given the modern lifestyle, this is what I would immediately think, that's got to be a lifestyle shift rather than a genetic change, because hasn't been enough time for it to be genetically based. But I'm keen to hear, like, are you like, what are your thoughts?
Yeah, I think my thoughts are very similar to yours. I think we're given that kind of amount of time. It doesn't the genetic aspect maybe doesn't really seem to. There might be a small aspect, but I think the hypothesis seems to be more that it's driven by like you say, modern lifestyle, the increased rates of obesity, decreased physical activity levels, and all of those kind of things.
Yeah. Terry, on that with physical activity, I'm super interested to explore the idea of, or that, your research area about sedentary behaviour, and of course, the role that exercise can play in the management of and potentially treatment of cancer. But first, can you remind us what the definition for sedentary behaviour? Because I wonder whether people, really understand what that means to be sedentary.
Yeah, sure. So I guess sedentary behaviour over the last kind of 10 or 20 years has really kind of popped up and received a lot more research attention as an independent risk factor that's distinct to not doing enough physical activity. So when we talk about sedentary behaviour, I'm going to use the Sedentary Behaviour Research Network definition because it's a really nice definition. So and I'll quote it. So it's any sedentary behaviour is any waking behaviour characterised by an energy expenditure that's less than 1.5 metabolic equivalent tasks while in a sitting or reclining posture. So there's kind of the three elements there are you have to be awake, so sleep isn't classified as sedentary behavior. It's when you're expending really low amounts of energy, and while you're in that sitting or reclining posture. So maybe what we're doing now, I think, would be classified as sedentary behavior if you're a Formula One driver or something like that, where you're awake, hopefully, and you're in a sitting or reclining posture. But they expend, huge amounts of energy, so that wouldn't be, even though they're sitting, that wouldn't be classified as sedentary behavior because it's they're expending vast amounts of energy.
Well, that's interesting, isn't it? Because I agree with you. And when I chat to people about sedentary behaviour, and they relay to me their role, and that's largely sort of knowledge-based career. So they're sitting in a computer, in front of a computer, but they're thinking a lot. And then they're like, well, I mean, yeah, I'm sedentary, but surely I'm, expending something because of all of the, my brain's doing all the work. Like, is that still sedentary behaviour?
I think I think that would be still classified as
I think
sedentary.
so too. Yeah,
probably more the physical aspect of energy expenditure. Maybe rather than the mental energy expended.
Yeah, nice one. Although people do say your brain uses 20% of your overall energy expenditure over a day.
Yes.
But yeah, that's right. So, and do you know, like, what percentage of people are sedentary for Australia? Because I imagine that's where you may have data for.
That's good. That's a deceptively tricky question because I don't think there's really an established definition of what might be classified as high sedentary times. I think So I know I was involved in writing a chapter for a book called Sedentary Behaviour Epidemiology, and one of the other chapters I think was really looking at this kind of descriptive epidemiology of sedentary behaviour, and they found that they looked at literally thousands of studies from around the world, and on average, or the median estimate of total daily sitting time was about 6.5 hours a day. But it's important to think about how sedentary behaviour was measured. So when they looked at studies which use self-report to measure sitting time, the median was 5.6 hours a day. But when they looked at studies that had used some kind of device to measure sitting time, the median was 8.3 hours a day. So you can kind of see. So when like we were talking about earlier, how the challenges in measures things, that's kind of a really good example there of how the way you measure something can give you a different estimate of what someone's sitting time actually is. And I guess, like I said, there's not really an established definition of what high sedentary time is, but I think from studies which have looked at sedentary behaviour and risk of mortality, it seems to be risk of mortality starts to increase at around that, like more than 6 to 8 hours of sedentary time a day. And I think, again, based on what the authors of that particular chapter looked at, I think they found the median prevalence of high sitting time was around 32% across all of when you kind of look at all of those studies as a whole. So yeah,
that's a huge section of population, which 6 hours though isn't a long. I mean, no, it is. It's like a quarter of your day, but of course, ideally, you'd be 8 hours of that would be in bed.
Yep.
But if I think about like the average in quotation marks, working day of about 8 hours, and a large portion of the population would be sitting for that work, and then they'd be driving to work, and then they might be sitting down watching TV afterwards. They might go to the gym at some point during the day, or go for a run, but you're still spending a large portion of the day in that low activity state.
Yeah, absolutely, and I'm sure I would put myself in that category absolutely, where you're sitting in front of a computer all day, and then I think it's pretty easy to rack up 6 or 8 or more hours of sitting time a day. So I guess that's something to be conscious of, and I think there's some research that shows that perhaps trying to avoid prolonged bouts of sitting can be potentially beneficial. So so not sitting for more than 20 or 30 minutes at a time. I know that's something since I've done research on sedentary behaviour, that's something I've been conscious of trying not to sit for really long periods of time. Again, I know it's easier said than done, but
yeah, sure.
Wherever possible.
Are you on a Swiss ball right now?
Sorry?
Are you on a Swiss ball right now?
No. Sorry, I'm on a rotating chair. So
nice one.
around a little bit. Probably a nervous tick.
Hey, so Terry, it's interesting, right? Because like sedentary behaviour comes up a lot when we think about obesity risk, the risk of type 2 diabetes. I spoke to David Dunstan actually a year or so ago.
To that one,
and which was really, really interesting. And of course, cardiovascular disease. And it feels like such an important sort of dial mover. But I find it interesting that to date, there's, you say, well, there's no real clear definition of this or this. Like, what is holding the research back and being really definitive about what it actually is, so we can therefore be more definitive about, I guess, sharing that information with people and bringing more public awareness, I guess.
I think a lot of it probably comes down to that kind of measurement issue where we know, I guess, when you're using, so most studies to date have used self-reported sitting time or self-reported time watching TV or something like that, and we know this kind of element of measurement error that's involved in those kind of things. And I guess because it's it's wouldn't say it's in its infancy still, but it's definitely, I guess, quite, as a field, it's kind of quite young, particularly when you compare it to something like physical activity epidemiology, which has kind of been going on for 30 or 40 years. So a lot of the kind of big cohort studies haven't which were started in the 50s or 60s or 70s. It was just they didn't really measure or have any information about sitting time. So we I guess there probably isn't just the vastness of studies which we see for something like physical activity to be able to be more confident in how sedentary behaviour is affecting these particular health outcomes, and particularly how much sedentary behaviour is detrimental.
Yeah, because it feels like you sort of need a huge research grant to do some huge observational trial where everyone gets Apple Watches or something, and you get like 100,000 people and you get their data over 2 years. Like, that sounds like a good idea.
Yes, absolutely. And I mean, there are some more recent cohorts and I guess the UK Biobank is an example of that, where they had, I think, 100,000. So that was a cohort study in the UK of about 500,000 people, and they also had a subset of that sample, so 100,000 people, which is a very big very big subset who wore an accelerometer for 7 days on their wrist. So again, it's not the best measure for sedentary behaviour, but it's perhaps better than self-report though.
Yeah, and I mean, I think people probably understand that sitting around a lot isn't that great for your health. What is the impact of sedentary behaviour potentially on cancer risk?
So again, that's something we don't really know all that much about. So so when we were putting together that chapter, or there was actually an update of that chapter a couple of years ago, we tried to find all the studies we could find that had looked at sedentary behaviour and risk of different types of cancers, and we found there were about 120 or so that had looked at 21 different cancer sites, and kind of based on the evidence from all of those studies, we found that the higher levels of sedentary behaviour were associated with a small risk increase for some cancers, so colon cancer, endometrial cancer, ovarian cancer, and pancreatic cancer. But we didn't have a huge amount of confidence in what those risk estimates actually were, just because of the small number of studies which have been conducted to date. And then there was also a small increase for breast cancer, but again, there's just not really the vastness of studies at the moment to have huge amounts of confidence in what those risk estimates actually may be.
Yeah. If I think about sedentary behaviour, I think about its impact on excess body fat, poor metabolic health, and whether that is part of that relationship that might be driving cancer risk, which I know from a research perspective you might not be able to see. I don't know, or can you?
I mean, I guess what we do as epidemiologists is, I guess, postulate or hypothesize about those potential biological mechanisms, and we look at like experimental studies. And I know, as you say, they talk to David Dunstan, and he's at the Baker. They've done lots of those kind of studies. So I guess in terms of how sedentary behaviour could potentially increase risk of different types of cancers, it's some of those things that you measured, like body composition. So increased adiposity or increased risk of obesity if you're more sedentary or have higher levels of sedentary behaviour, and also the impact of sedentary behaviour on things like sex hormones, metabolic function, and inflammation and immune function. And we know all of those things play a role in carcinogenesis or the development of cancer. So that's kind of how we think that sedentary behaviour could potentially be affecting cancer risk.
I also find it interesting, like when we try to, when researchers when they're trying to isolate one particular factor as being, how important is this one particular thing, whereas often behaviours cluster and it's patterns, right? Like, so if someone is more sedentary, maybe they also are more inclined to eat less fruit and vegetables, or to drink more alcohol, or do less physical activity, which is in itself potentially a risk is associated with risk. So, and is it important to understand these independent risk factors, or is it more important just to understand patterns of behaviour?
That's a really good question. I think I'm going to sit on the fence and say both. I think both of those things.
That's your classic academic. Yeah.
But I think that's a really good point, though, because I guess that's absolutely one of the challenges when we are looking at say how physical activity influences the risk of a particular cancer. We know that there's lots of different risk factors for different types of cancers, and lots of those are lifestyle related. So it can be quite challenging to kind of isolate how one particular risk factor affects a particular cancer. So I guess that's when we really need to think about confounding and really put in our kind of causal inference hat and think about the difference between confounders and what might be mediating or biological pathways and those kind of things to try and build statistical models which we think are most appropriate for that research question.
Yeah, interesting. And I'm like, that's so interesting how you talk about it, because of course that's what you do. You're looking at like I know you do more than this, but just in that instance, you look at data, you build statistical models to try and then you must swap things in and out to sort of see how much of something explains something else. I don't know, like it seems very complex, which I admire hugely because I can do it. I'm no statistician.
There's definitely and like I said earlier, there we really spend lots of time thinking about confounding as epidemiologists, and kind of trying to think about that. I guess things like biological pathways and that kind of exposures and outcomes, and what things are causing those particular exposures and what things are causing the outcome that we're interested in, and that kind of interplay between all of those things. So we certainly spend a lot of time trying to take that into account as best we can.
Sitting at your desk, working out algorithms.
That's right. Expending a lot of mental energy.
Exactly, but not as much as a Formula One driver.
Exactly. Yes.
Hey, so if I think about sort of flipping it on its head and thinking about activity, are there any misconceptions around physical activity for cancer patients? This is an entirely different subject now. I've moved on. What are some risks, and are there misconceptions around the risks or benefits for physical activity for people with cancer?
I think there absolutely are, and I think a lot of that is historic, where we know that if you think back to probably 30 odd years ago, cancer patients, if you're diagnosed with cancer, I think the general advice was to rest, avoid physical activity, avoid strenuous activity, as it was thought to probably be harmful to people who'd been diagnosed with cancer. But I think that the kind of early exercise oncology research, looking at how physical activity and exercise in cancer patients, which kind of started in the 90s and 2000s, really started to challenge that misconception, or that advice about avoiding activity. So I think there's still some uncertainty. Maybe it's kind of a hangover from I guess those misconceptions sometimes take a long time to go away. But I think there is some still uncertainty around there about safety and suitability for exercise and physical activity in general for people with cancer, and also a lack of awareness about all the benefits that exercise does have for people with cancer.
Yeah, and what are those benefits?
There's a huge number of benefits, and there's been and I think there's over the last kind of 20 to 30 years, that field of exercise oncology has exploded. So there's lots and lots of really good evidence showing that exercise and specific doses of aerobic exercise or aerobic plus resistance training can improve lots of really common cancer-related health outcomes, and not just physical health outcomes. So we're thinking about mental health outcomes as well. So things like anxiety, depression symptoms, fatigue, physical function, health-related quality of life, and I think also reduces risk of lymphedema as well, and other kind of outcomes. There's also evidence, not as strong as some other outcomes, but things like peripheral neuropathy and perceived cognitive function as well. So I think, so this is just like a myriad of benefits, I think, for exercise and physical activity after a cancer diagnosis. And there's also and also in terms of actually increasing survival as well after being diagnosed with the cancer. So from observational studies, there's quite accumulating evidence that physical activity can improve survival in people with colorectal cancer and breast cancer and prostate cancer. And I know for all of those, there's actual randomized controlled trials going on as we speak to generate stronger evidence about how exercise can potentially improve mortality in people diagnosed with those cancers. And I think there's lots of people, including me, who are very much looking forward to seeing the results of those RCTs.
Yeah, sure. And Terry, is it for people who were previously or would consider themselves active people, or is it more beneficial for active people over people who were formerly sedentary? Is there a difference there between level of benefits?
I think for cancer patients, I think in the general population, and I think it would be the same in people diagnosed with cancer. Absolutely, like I said, at a population level, absolutely the biggest bang for your buck is if you go from the most improvements you might see in health when you go from doing nothing to doing something. And something can be a very, very low level of activity, but that's that when you kind of think about how physical activity can improve and reduce cancer risk or improve these health outcomes, is definitely that kind of initial step from going from doing nothing to doing something is where you really see the big health outcomes. And for most of those health outcomes, it's absolutely kind of the more you do, the more these health outcomes will improve, and the more your risk of these things like cancer are going to decrease as well.
What a great point, because even though we were talking about the management of or physical activity throughout treatment, it's obviously there's a risk reduction for people to be active to help reduce risk of being diagnosed with cancer as well.
Yeah, absolutely, and there's that's somewhere where like I said, my PhD was on physical activity and risk of colorectal cancer, and there's been for lots and lots, there's been literally hundreds of, probably thousands of studies looking at physical activity and reduced risk of lots of different cancers. And I think there's really, really good evidence now that physical activity reduces the risk of a wide range of cancers. Yeah, and there was a review which came out a couple of years ago, which looked at all of these studies that had looked at physical activity and reduced risk of different cancers, and I think they concluded there was really strong causal evidence that being physical activity reduces the risk of 7 different types of cancers: so breast cancer, colon cancer, bladder, endometrial, kidney, esophageal, adenocarcinoma, and gastric cancer, and then also moderate or weaker evidence for an additional 8 different cancer sites, and they were non-Hodgkin lymphoma, rectal cancer, head and neck cancer, myeloma, myeloid leukemia, liver, small intestine, and gallbladder cancer. So that's, I think, how much is that altogether? 15 different cancer sites. Yeah, that's right. Yeah, so there's and given the really large number of studies that have been conducted on some of those cancers, I think we can be quite confident that being physical activity is absolutely beneficial for reducing cancer risk.
Terry, I hear information like that, and I'm aware of it, and I'm an active person myself, and I feel really lucky actually that I discovered that being active was awesome when I was like a teenager. So I've had decades of being active, and I really feel for people who aren't in my position where it feels like a hard task to become active. So with the data that is available on prevention for so many chronic diseases, if I say it baffles me that more people aren't active, that's not motivation enough. As I'm like, wow, really? That's not going to motivate you to do it? I don't know. You're in the field. Do you feel similarly?
Yeah, I guess I do to an extent. I mean, yeah, I don't really do much work in that kind of in terms of physical activity interventions. Yeah, trying to increase physical activity. Yeah, but I do. Yeah, and I know there's lots of thought and lots of discussion about the best kind of health promotion messages and guidelines and how we can get people to be, or how we can get the population to be more physical active as a whole. But I think, at least in Australia, I think that physical activity levels, I think, are pretty stable. So there's not.
Yeah.
It seems to be a very challenging thing to do to increase physical activity levels. And I guess I think it also, like, I put my public health hat on. That's difficult to say. And we think about things like the social determinants of health. So I think I'm like you, where I'm maybe like in a quite a privileged position in terms of knowing about the benefits of physical activity and being able to to be physically active. But we think we know lots about the postcode that people are born in influences their health outcomes, and also how easy it may be for them to do things like go to a gym, and that kind of what kind of infrastructure is in their area to allow them to be physically active, like walking paths or bike paths and those kind of things. So I think it's also important to kind of think more broadly rather than kind of putting it solely at that kind of individual level.
Yeah, no, for sure. And it's definitely worth mentioning probably that just because you're physically active doesn't necessarily prevent you from getting cancer, because of course so many people who live very healthy lifestyles are still diagnosed with cancer. So I guess it's not like it's a get out of jail free card. So of course I want to acknowledge that it's not like an alternative.
Yeah, absolutely. Yeah, 100% reiterate that. And I think that's, I guess, one of the challenging things about cancer is that kind of that element of randomness, or chance, and whether that's things, whether that is that randomness or things that we don't understand fully yet. And I'm sure everyone knows people that have done all the right things and have still ended up being diagnosed with some kind of cancer.
Yeah, for sure. Before we move on into looking at resistance training particularly, I think you raised a really good point when you were talking about the benefits of physical activity. Just benefits in everyday life is, of course, how for our mental health and how good we can feel. And as I understand it, people who go through a cancer diagnosis really benefit from that psychological aspect of being physically active.
Yeah, that's right. And I guess so things like anxiety and depression and fatigue and those kind of things are much more. Or if you have been diagnosed with cancer, you're generally at a higher risk of experiencing one or more of those mental health related challenges because of the side effects of cancer and treatment and those kind of things. So I think that's really kind of positive news that there's quite good evidence showing that engaging in physical activity and be it aerobic or resistance training can help to improve those kind of common cancer related side effects.
Yeah. And Terry, with regards to research and weight training, and particularly resistance training, what does the research tell us about the relationship there with cancer and resistance training?
For resistance training and risk of cancer, I think there's only really been I think I'd probably say less than 10 studies which have looked at this. So I don't think we really know too much about how engaging in weight training. I guess so when we're talking about weight training and resistance training, we're thinking about those kind of exercises which strengthen the muscles, really. So things like weight training, even things like yoga and Pilates, I think can kind of fit under that broad muscle strengthening exercise umbrella. There's been a few studies on colorectal cancer, and they've generally found that engaging in resistance training and muscle strengthening exercises may decrease the risk of colorectal cancer. But for other cancer types, it's probably a bit early to know what may be, whether there's any associations going on there.
Yeah. And your because you did you do a randomized controlled trial in this?
No, not a randomized controlled trial, but I did was involved in a systematic review and then also an actual study where we looked at resistance training or weight training and risk of mortality, so all-cause mortality, and then cancer-specific mortality and cardiovascular mortality.
Yeah, that's right. And that was the one where women tended to respond better than men. Is that correct?
Yeah, that's right. In the actual in the study, where we used data from a big cohort study from the United States, and with collaborators from the National Cancer Institute in the US, so we found that engaging in any amount of weight training was associated with a lower risk of all-cause mortality, and as well as cancer mortality and cardiovascular mortality. There were risk reductions around 6 to 10%, so not enormous, but definitely, but still quite meaningful. Yeah, and interesting. Yeah, and like you mentioned, we found larger mortality risk reductions among females than males. And we don't really know why that is. We did give it a thought. We couldn't really think of any
reason for that.
Yeah, reason for that. And we were I think there's other studies which have looked at those potential sex differences, haven't really found any difference. So we're not. Yeah, we know whether it could potentially just be a chance finding rather than anything real. But I think we really need more studies to see if there is a difference.
Yeah, super interesting that any amount of resistance training, and under that umbrella, we're thinking yoga, Pilates, you're in a gym, you're using bands, or any type of muscle strengthening exercise in that state is going to be beneficial.
Yeah, that's right. Yeah, so in that study I was just talking about, we only had information specifically about weight training. So I guess which would traditionally be the kinds of I guess using weight machines and those kind of things at the gym, or dumbbells and barbells, that kind of thing at home. But in the systematic review we did of all the studies which have looked at resistance training, they had most of those had those other kind of muscle strengthening exercises under that broad umbrella of resistance training, things like yoga and Pilates, and it doesn't really seem to require much in terms of what that dose response. But again, I guess maybe like with physical activity, I guess it's really going from, if you go from doing nothing to doing some level of resistance training, then you're going to see some health benefits in terms of reducing your risk of mortality.
Yeah, and did you know the sort of the exercise history of the participants per se in the study that you did particularly?
No, we only really had information about weight training at one point in time in that baseline measure, and I think that's definitely an avenue for future research, where if you have information about resistance training at multiple time points, then that gives if we again thinking back to the measurement kind of issues as well, that also gives us a lot more robust estimate of how much resistance training, for example, people are doing if we have information at like 3 or 4 different time points 2 years apart or something like that.
Yeah, for sure. Terry, is it to do with like muscle cachexia and that loss of muscle mass across the treatment of cancer? Is this one area where you think the weight training could be beneficial? Is that something that any of your research has investigated, or?
I haven't really done much in terms of resistance training in people with cancer. I haven't done any research in that, but I think that's definitely but I think one of the reasons that resistance training can potentially be useful for and improve these health outcomes in people with cancer is that by I guess doing muscles that are doing exercises that are strengthening your muscles, it is helping to reduce things like cachexia and those kind of things, and then I think also allowing you to actually do aerobic physical activity as well. So I think there's absolutely a synergy, I think, between resistance training and aerobic physical activity, where I think they probably both lend themselves to improvements in the other.
Yeah, nice one. And I guess I have a bit of knowledge on, the number of people who might do resistance training in the general population, not a lot, which means that probably there's a lot to be gained, as you said, like novices in the area. If you were in that situation, hadn't yet done resistance training, then you've got a lot of potential benefit from doing it in the case of, whilst you're undergoing treatment, etc.
Yeah, absolutely. Yeah, like you mentioned, I think in the general population, the prevalence of weight training is, I think it's less than 20%. So, it's very, very low. So I guess, I think if there are those potential, mortality benefits for the general population, or those more benefits in more particular health things for people with cancer. If at a population level, given the low prevalence at the moment, there's there's definitely potential to improve lots of those health outcomes at the population level by increasing prevalence. I actually started doing weight training after being involved in that study.
Oh, did you? Yes. Nice one. That's good. Actually, one of my questions was going to be like, how has your research sort of changed the things that you do in your life? So obviously that's one of them.
Yeah, absolutely. I think like I mentioned before in that doing the PhD on sedentary behaviour, and I guess that was back 15 or so years ago when sedentary behaviour research was really starting to kind of take off. So actually reading all of those studies and understanding that difference between sedentary behaviour and not doing enough physical activity, I think that absolutely changed my health behaviours at that point.
Do you have a standing desk, Terry?
I do. I at home I don't. So I'm at home at the moment, so I'm sitting. But at my work, I have a sit-stand desk. But
that's good.
Full confession, it's in the sit position more than it's in the stand position.
Oh, do you know what I find for me personally is that I can do standing when I'm doing like interviews is fine, or I'm doing messaging with some of my clients or my groups. But if I have to actually think, and then if I'm prepping for an interview or if I'm doing some writing, I have to sit. Like I'm not one of these people who can walking pad and think at the same time. Like I just cannot do that multitasking.
Yeah, no, I'm exactly the same. So if I'm doing data analysis or writing a manuscript or something like that, or I have to engage my brain a bit more than normal, I'm absolutely sitting is much. I find sitting much more conducive to that.
Yeah, 100%. Hey, Terry, one other study I wanted to ask you about was one that I saw related to like both, I think, polygenic risk for cancer. I'm not sure if I've said that correctly, but where you're looking at, where your research group were looking at multiple genes and risk of cancer. I think that's right. Can you just give me a little bit of a background into what you guys were actually looking at in that study? Because I think people would find it really useful to understand more what the research is really interested in.
Yeah, sure. So I guess what we were really interested in that study was looking at the combined effect of genetic risk factors for cancer and lifestyle-related risk factors for cancer. So like we've talked about, we know there's lots of lifestyle factors that are associated with the risk of lots of different cancers, and we also know that genetic factors also have an important role in the development of cancer. So what we really wanted to look at in that study was whether the relationship between those lifestyle-related risk factors and cancer risk differed by genetic risk, and also whether there might be particular population subgroups. So, for example, those who are at high genetic risk of cancer, whether they may benefit more or benefit less from lifestyle intervention programs, or by adhering to lifestyle recommendations. So that was kind of the rationale for why we went about doing that study.
Yeah. How do you even investigate that?
I rely on people who are much more expert in genetic epidemiology than I am, so the other members of the team. But I guess in terms of actually understanding what someone's genetic risk is, so like you mentioned, we used polygenic risk scores, and I'll have my best go at explaining what that is.
Do it. I wouldn't understand anyway, so it doesn't even matter.
So basically, we know that there's humans have hundreds of thousands of genetic variants, and through what are known as genome-wide association studies, researchers can investigate which of those genetic variants is associated with the risk of a particular disease or a particular trait. But those on their own, those individual genetic variants typically have very, very little impact on the risk of a particular disease, or, for example, a particular cancer. But when we actually look at them, assess them collectively, and that's what we're doing when we use a polygenic risk score. We're kind of looking at all of those genetic variants and how they influence a cancer kind of as a whole. Then we can see that they actually do, having a greater number of those genetic variants can quite substantially increase the likelihood of developing some cancers. So they really have that kind of utility in helping to identify people who may be at higher genetic risk of particular cancers.
Yeah, and then of course you mentioned that you then look at them through the lens of the lifestyle behaviours that are also place someone at additional risk. So what kind of lifestyle behaviours, and actually what kind of, I guess, ultimately, what were the strongest associations that you found, that your team found?
In terms of, so we looked at we looked at lifestyle as a whole. So rather than looking at the individual rather than looking at individual risk factors, we looked at kind of adherence to lifestyle recommendations, kind of as a kind of index. So there's an organisation called the World Cancer Research Fund, which is really kind of the authoritative body on these lifestyle related risk factors and cancer risk, and they have put together some recommendations for these lifestyle related risk factors to prevent for optimal cancer prevention. So it takes into account things like physical activity, being a healthy weight, eating whole grains, vegetables, and fruit and vegetables, limiting intake of fast food, limiting intake of red meat and processed meat, limiting sugar sweetened drinks, limiting alcohol consumption, not smoking, and being sun smart. So we kind of use those to develop a lifestyle index based on, we didn't have information on all of those, so we used the UK Biobank, that study that I talked about earlier. So the information that we did have, all of those, we kind of essentially created a lifestyle score for each individual based on how closely they adhered to the recommendations for each of those individual risk factors.
I can't imagine many people would have had close to all of those factors. Am I right?
I suspect you are. I don't have that information on hand. I would be surprised. I think that the maximum score that someone could get was 7. So if they, ticked off everyone, I suspect there weren't very many 7s, but
no.
Off the top of my head, I don't know that. That's a good question.
I just, in my PhD, one of the things I looked at was a cluster of just like 4 behaviours / health outcomes, the usual ones, fruit and veg, physical activity, alcohol, or not smoking, and BMI or something like that. And there were like, I don't know, maybe 4.1% of the population, or based on the data that we have in New Zealand, like tiny amount of people actually do all the things which we're suggested to do. So I suspect I would be like you, surprised if lots of people were doing everything right, quote unquote. Right. And from your paper, and of course we will pop the link to this in the show notes, there were no, as I understand, there was no evidence for multiplicative interactions, so multiple interactions, but there were significant additive interactions for certain cancers. So can you just briefly outline what those were and what that means? Like, what does it mean when something's an additive risk factor? Yeah, sure.
Again, this is something that these are that difference between multiplicative. I have trouble saying that. It's multiplicative interaction, additive interaction. It's really subtle, and to be honest, I have to kind of go back and read papers for about an hour or so to really understand.
I understand.
To get my head into that space. But I guess basically, again, I'll have a go at explaining this. When we're talking about interaction in general, that we're basically kind of looking at the combined effect of 2 or sometimes more than 2 exposures or risk factors on a particular health outcome, and at whether the effect of one of those exposures on a health outcome is different in different types of people. So I guess we're kind of really thinking, is the whole of the combined effects of those 2 things more or less than the sum of the 2 individual parts, or of the product of the individual parts? And that kind of sum or product is really the difference between additive and multiplicative interaction. So if we're testing whether the combined effect of 2 things is more or less than the sum of the individual parts, so kind of adding them together, then that's where we're testing for additive interaction. And if we're thinking about whether the combined effect of those 2 exposures is more or less than the products, and we kind of multiply them together, then that's when we're looking at multiplicative interaction.
So it's kind of like if you've got 2 things, if it's a multiplicative, you'd get this absolute explosion in terms of risk. Like it's way more than the sum of those 2 things together. It's actually like, whoa, these 2 things together are really increasing risk over and beyond, or decreasing risk above and beyond what you would expect.
So if it's multiplicative interaction, then it's more than the product of those things.
That's
nice. Yeah,
Yeah.
that's right. So I guess it's been, I think historically it's been much more common to look at multiplicative interaction, and perhaps because that's from a statistical perspective or analysis perspective, that's much more straightforward to do than it is to additive interaction. But there's quite good arguments, I think, that assessing additive interaction is probably more relevant from a public health perspective, because and for clinical decision making, because when we're looking at additive interaction, it's really giving us insight into whether there might be population subgroups which may be best to treat or to deliver an intervention in. So that's why in this study we decided to looked at both multiplicative and additive interaction, but with, I guess, what that additive interaction and test is giving us information about whether following lifestyle recommendations could potentially prevent more cases or fewer cases of cancers in people with a higher genetic risk of cancer than in the same number of people with a low genetic risk of cancer.
Yeah, and as I understand it, there were some cancers, there were some significant sort of findings for. Can you brief us on them, Terry?
Yeah, so overall we found that the great adherence to lifestyle recommendations was associated with a lower risk of overall cancer, and also of 8 specific cancer types. So we looked at 13 common cancers, and we found significant risk reductions for 8 of those. So they were colorectal cancer, postmenopausal breast cancer, lung, kidney, uterine, pancreatic, bladder, and oral cavity cancers. Yeah, so for all of those cancers, it's greater adherence to lifestyle recommendations was associated with a reduced risk of those things, and that was independent of genetic risk. So regardless of whether you're at a low genetic risk of cancer or a high genetic risk of cancer, the adhering to those lifestyle recommendations lowered your risk of those particular cancers.
Nice. And then when you took into consideration that the genetic component, there were some significant findings there as well?
Yeah, that's right. Yeah, so for some specific cancers, I think so colorectal cancer, breast cancer, and pancreatic cancer, we found that adherence to lifestyle recommendations for cancer prevention may be of even greater benefit for those who are at a high genetic risk, genetic risk for those particular cancers.
Yeah. And so from when you guys conduct studies like that, it could have significant public health implications, right, for how you might then target specific populations and the public health messages that they might get. Is that where this kind of research heads? What can we do with this information, I guess?
Yeah, I think so I guess that's the idea, is you might accumulate evidence from these kind of studies to get more confidence in the results, and I guess that can potentially tell you whether there might be sections of the community or those who are at high genetic risk of cancer who may be more likely to get kind of more bang for their buck, so to speak, out of doing being physically active and not smoking and all of those kind of things. So I think there's definitely potential for I guess kind of public health messaging and those kind of things to maybe target those people who are at high genetic risk of cancer. But I think really the thing I was most excited about from this study was actually finding that the risk reductions for all those different types of cancers was independent of genetic risk. So It didn't really matter. Even if you were at high genetic risk of cancer, we still know that you're following those lifestyle recommendations can reduce your risk of that cancer, which I think is like a really powerful message, I think.
Oh, 100%. You're right. Because this means you don't necessarily have to go and pay out of pocket for genetic testing to discover what your risk is, to then go, is it a really good idea if I go do resistance training and stop smoking? And I mean, even saying that, I mean, of course it's a good idea to do resistance training and stop smoking, but I think you're right, messages like that, like the whole lifestyle message, has real possibility for people who may need, I don't know, additional motivation or something to get out and actually do things to help reduce risk for overall negative health outcomes. I don't know.
Yeah, absolutely. Yeah, I agree 100%. And I think it's I guess, but perhaps there's a kind of a misconception that if you are at a high genetic risk of some of these cancers, then there's not really much you can do about that. Whereas, I think like studies like ours, show that there are actions that you can take in your life, or changes you can make to your lifestyle that that can actually have an effect on your risk of developing a particular cancer.
Yeah, nice. And now all we need really, Terry, are multi-billion-dollar marketing campaigns given to that public health can roll out that are as compelling as, say, McDonald's. And then we may see some sort of traction in that public health space.
Yeah, I think that's the dream of people working in public health.
Yeah.
I think the reality is that in Australia, and I'm sure
New Zealand
it's the same in where the actual kind of from a government or federal budget perspective, the amount of money that goes towards prevention is very, very small.
Yeah, for sure.
Unfortunately.
I know. So, Terry, where next, or what are you focused on now with regards to your work in this particular field?
At the moment, I'm working on a few different things. At the moment, I guess one is looking at using the UK Biobank. So I have a PhD student who's looking at physical activity and risk of cardiovascular disease,
nice
and also looking at how physical activity might influence survival in people who've been diagnosed with different types of cardiovascular disease. So I think that's we're seeing some really exciting results for those studies. And I've got kind of a new research interest is looking at hopefully looking at applying for grant funding to look at risk factors for second cancers, which is kind of kind of a new area for me. But I'm quite excited and hoping to get some funding to be able to look at that kind of thing.
That's right, because you wrote, was it for The Conversation? Or it was a publication earlier this year asking the question, if I have one cancer, what's my risk of getting another of cancer reoccurrence, or the same or a different type of cancer? Is that right?
Yeah, that's right. Yeah, so I co-wrote that with a postdoc from we had the Walter Eliza Hill Institute. I hope I said that correctly. Something like that. And that's not something. And I was I guess for that article I was looking specifically at that second thing you mentioned. So if you've been diagnosed with one cancer, are you at a higher risk of being diagnosed with a second unrelated cancer?
Yeah.
And it's not something I'd really looked into very much before. But I guess through writing that, in kind of doing the research to write that article, I found that there's quite good evidence that if you have been diagnosed with some kind of cancer, that you are at a higher risk of developing a second primary cancer. And estimates from Australia suggest that risk increases somewhere between 6% and 36%, and varies quite a lot by the type of initial cancer that you may have been diagnosed. But as a kind of overall, that seems to be where that is. One thing that really surprised me was that of all the cancers that are diagnosed today, at least in Australia, and again, I'm sure the same in New Zealand and most developed countries, around 1 in 5 of those are diagnosed in people who have a previous cancer diagnosis. So 20% of all cancers are diagnosed in someone who's already had cancer before, which I'm still, even saying that now, I'm still really surprised that figure is as high as it is. And a lot of that is driven by improvements in treatment, improvements detection, and those kind of things. So people with cancer are living longer than ever before. But the I guess the unfortunate consequences of that is that they are more likely to develop a second cancer just because they're living longer.
And Terry, what is your project hoping to investigate? What is your grant looking for at?
It's really to look at those kind of lifestyle related factors. I guess to do some similar work where we developing those kind of lifestyle indexes to look at whether adhering to those lifestyle recommendations as a whole can potentially reduce your risk of developing a second cancer. And also, I think looking at those risk factors individually as well, because there's not a huge amount of research out there that has looked at those kind of modifiable risk factors and what role they could play in development of a second cancer.
Nice one, Terry. And I got to say, in this particular area, I don't think you'll ever be short of a research question or anything like that, because it seems like for every question that is answered, another 5 seem to pop up, when it comes looking at chronic disease and the rest of it, and particularly cancer. I don't know. And I know that there are inroads being made in certain areas of treatment and whatever, but then it seems like there's an explosion of cases, and I don't know, it feels all a bit I understand it's something that might be on people's mind quite a bit because, as you say, people know someone with cancer, then themselves have been diagnosed with a cancer, and it seems prevalent, really.
Yeah, that's right. Yeah, and like you say, I guess that's one of the things I enjoy working in cancer is we have there's lots of different cancers to study, and lots of them have quite different risk factors, and we also know like some cancers like colorectal cancer where there are lots of established risk factors that we know about, where there's other cancers. I guess like I've done some work in non-Hodgkin lymphoma where there's just the evidence isn't really there for a lot of in terms of risk factors. So I think so it's I enjoy that challenge.
Yeah, it's like job security if there's funding.
I guess so. Yes.
Yeah.
It's just a matter of getting the funding to actually do the research.
Yeah, totally. Hey Terry, thank you so much for your time this afternoon. I really appreciate it. I will put a link to your ResearchGate and your Twitter, and of course your bio in the show notes. Is there a web page or anything where people can find out more about what your research group is up to? Where is the best place to find out that sort of emerging stuff?
Yeah, probably the best is my UniSA staff profile. That probably
nice
has
one.
the most comprehensive information, and that's and the most up-to-date information.
Yeah. Awesome. Terry, thank you so much.
That's okay, my pleasure. Thank you.
Yeah, you're welcome. And enjoy the rest of your afternoon.
Thanks.
Alrighty, hopefully you enjoyed that chat that I had with Dr. Terry Boyle, and just some super interesting research coming out there, which just gives us indication. And look, there's probably a lot of it might make logical sense that if you live a healthier lifestyle, then you're going to be at less risk of diseases like cancer. But I really like knowing some of the ins and outs of that research. So I hope that you got something from that interview as well. All right, team, next week on the podcast, I speak to Daniel Rowlands, who is a running coach all about training for ultras, because that's something I'm super interested in. So I look forward to sharing that with you. Until then, though, you can catch me over on Instagram, Threads, and Twitter at Mikki Williden, Facebook at Mikki Williden Nutrition, or head to my website, mikiwilliden.com, and you can sign up for Recipe Portal access or book a one-on-one call with me. All right, team, have the best week. See you later.